So, okay, you should be able to see my screen.
Yes,
hopefully.
yes, we can see it.
Okay, great. So the topic I was asked to talk about is cerebral endoscopy, which is actually a very, very large field. So it was kind of a difficult task for me to summarize somehow not only what I do about cerebral endoscopy, but what can be done in general. I made a choice to go through these different operations that we can do with an endoscope in the ventricles or in the brain, following an anatomical scheme. I will start from the lateral ventricles to move on to the third ventricle, the cerebral aqueduct, the fourth ventricle, and also some operations that can be performed along the whole CSF pathway. I also decided to talk mainly about flexible endoscopy. All of you know that we can use rigid or flexible endoscopes. So I, of course, will talk also about rigid endoscopy, but I will focus more on flexible because I think it's the less commonly used worldwide, besides probably some Asian countries. So we can use both flexible scopes or rigid scopes. Then probably during discussion, we can also talk about these different choices. And we can do some quite easy, I would say, operations in the lateral ventricles, like septostomy, for example, when one of the two lateral ventricles are blocked, we can just insert a rigid or flexible endoscope and make a hole in the septum pellucidum, like I'm doing in this case of a 25-year-old girl with a monolateral Monroe foramen stenosis. And as you can see, after performing this septostomy, we can navigate into the contralateral lateral ventricle. Sometimes we can also perform some biopsies of tumors in the lateral ventricles, like I did in this case of a 71-year-old woman who presented with 1.5 centimeters enhancing lesion at very close to the Monroe foramen, the right Monroe foramen, which is here, as you can see. And after entering the lateral ventricle, we could actually see this brownish area on the floor of the lateral ventricle. So I will move on faster, of course, for the sake of time. I started doing coagulations in this area of the ventricle, of the ependyma. Making some coagulations is quite safe. There are no important functions here in this anterior part of the floor of the lateral ventricle. And as you can see, we can use forceps. In this case, I used a rigid scope because the trajectory was very straightforward from the bar hole, a frontal precoronal right bar hole. And using these forceps, I could take not only bioptic samples, as you will see, but at the end of operation, I could obtain almost complete resection of this tumor. So some lucky cases exist, like in this case. And then after the operation, after a removal, I used the fluorescing sodium just to check the field, the surgical field after the operation. There are cases where the patient has a biventricular hydrocephalus due to the atresia of the Monroe foramina, like in this case of this patient. These are pictures, intraoperative pictures, showing there was a membrane occluding the Monroe foramen. And with a flexible or rigid scope, it is quite simple to perforate, to fenestrate this membrane. Of course, we have to be very careful in selecting the fenestration point, because we don't have to forget that here at the anterior medial margin of the Monroe foramen, we have the fornix that must not be damaged. And this is the postoperative coronal MRI showing that we were able to open the right Monroe foramen compared to this pre-op MRI. Of course, in these cases, we have to make sure that there is a septostomy, otherwise we have to perform it. Another interesting application of endoscopy in the lateral ventricles is represented by choroid plexus cauterization, which has historically been used, especially in developing countries like in some African countries, with the aim to control the hydrocephalus in infants. After many years of basically where we neglected this kind of operation in developed countries, a few years ago, a North American paper, systematic review and meta-analysis, was published, bringing up to interest this kind of operation also in developed countries. So this is another interesting option that endoscopes give us. Of course, moving on from the lateral ventricle to the third ventricle, the most common probably surgery performed with the endoscope in the ventricles is the third ventriculostomy. In this video, we can see an example of this third ventriculostomy, navigation through the Monroe foramen. Here we are at the anterior part of the third ventricle. This is the tuber cinereum, anterior, just anterior to the mammillary bodies. And then we can perform, of course, a fenestration at this in this area. Some people use coagulations. Some people avoid doing coagulation and prefer a mechanical fenestration. Personally, I base my choice on the situation of the specific patient. Sometimes, if it is possible just to poke the tuber cinereum with my monopolar coagulation, I do it mechanically. Sometimes this membrane is quite stiff, so I do some coagulations like I did in this case. And then you can, of course, enlarge the stoma with Fogarty balloon. Sometimes, as you can see in this image, in this video clip, there are some small bleedings from small capillaries at this level. So we don't have to be worried. Of course, we have to take into consideration the fact that in the interpeduncular cistern, the basilar artery is running, so we have to be careful in selecting preoperatively and intraoperatively the point of fenestration. But if we have these small bleedings, we just have to irrigate, keep irrigating. So in almost all cases, when I had this kind of intraoperative problem, I just did irrigation and the bleeding stopped. In only one case, I had to use the dry field technique, which is basically the removal of CSF from the ventricles. In that case, the bleeding stops basically immediately after removal of the fluid, and the vision is much clearer. It's always a good habit after performing the ventriculostomy to inspect the cistern to make sure that no other membranes are present. Of course, third ventriculostomy has many indications. The commonest are the obstruction of the cerebral aqueduct, like in this case, where this patient had a cavernoma occluding the cerebral aqueduct, so no need to go to the cavernoma in this case, because the patient had symptoms related to hydrocephalus only, and we did third ventriculostomy, the patient was fine. And this is also another interesting case we published of an adult man with a huge aneurysm of the vein of Galen that gave him actually obstructive triventricular hydrocephalus. Also in this case, third ventriculostomy can solve the patient's problem. Our group also published, but also many other groups published the possibility to use third ventriculostomy also in those patients who were operated during childhood for VP shunt and who are admitted later on with a shunt malfunction. So it has been established already by many studies that we can offer these patients an ETV as a first choice, because this operation has a success rate between 60 and 70%, which is not low if you think that we can help these patients get rid of their dependency on catheter. In our experience, I have already mentioned, we use the fluorescing sodium intravenous administration in several cases with different aims that I will talk about later. I want to show you these pictures, intraoperative pictures, when we used this intraoperative fluorescing sodium administration to show you that the point we use for performing a third ventriculostomy, which has always been defined like a non-functioning area, actually it's not really an area without function. In this area, in the tuber cinereum, there is a circumventricular organ called median eminence, which is actually which is an area with some functions. It's important for the balance of electrolytes and many ions in the homeostasis of many ions in the blood. So after detecting this area, we always try to avoid the stoma to damage too much this area, and we place the stoma accordingly to the position of the median eminence. I decided to show you these publications just to point out that sometimes performing a third ventriculostomy is not so easy, although it's considered one of the basics of neurosurgery, but it can be a very risky procedure sometimes if the anatomy is not favorable. So there are some publications saying that sometimes it is wiser to abort such kind of procedure and accept the fact that it's better to place a VP shunt, or sometimes to consider different sites for third ventriculostomy, like suprapineal recess, or even the lamina terminalis, as some colleagues published. In the third ventricle, we can also do other kind of operations with an endoscope, like tumor biopsies. See this case, Ludovico, is a 7-year-old guy with this hydrocephalus due to a very large tumor of the pineal region. So in this case, we went for an ETV to solve the problem of the patient, the first problem, the most urgent problem, which was hydrocephalus. And I will move on faster. Here I'm exploring the cerebral aqueduct with a flexible scope. This is the fourth ventricle. So as you can see, the aqueduct is patent, but the additum is compressed by the very large tumor. So here I'm doing an ETV. I always do ETV first. Here I found a membrane which I fenestrated, and I later on took some biopsies of the tumor. So with the same bar hole, we can obtain both the resolution of the hydrocephalus and tumor samples. As you can see from this video, I use this technique of rotating the forceps when I grab the tumor. It's a technique that we can call like the spaghetti technique, if you want, as I am an Italian. And rotating, you can actually detach some samples. Again, some blood, of course, will appear, maybe hampering your vision, but irrigations will be enough to get rid of these small bleedings, as you can see. This is the result, preoperative MRI, and this is the postoperative MRI. Of course, the tumor is there, but it was a radiosensitive tumor, so the patient went for radiotherapy. But please notice the shape of the anterior third ventricle, which recovered its normal anatomy. Our group several years ago published the usefulness of fluorescing sodium in some of these cases, especially when the tumor is not exophytic, but it's very difficult to detect with the normal light, like in this case. So with normal light, it's very difficult to understand where to take the sample for the biopsy, but when you administer fluorescing sodium and you use the proper filter, the areas, the enhancing areas appear very evident. Some groups even publish the possibility to take some biopsy of basal cisterns through the ETV in cases of basal meningitis and hydrocephalus, when, of course, other diagnostic methods are not able to detect the microorganism responsible for the pathology. And the same group, very interestingly, published the possibility to take biopsy samples from the brainstem, again through the ETV. It looks like a very difficult procedure. Actually, it must be performed only at the end of the learning curve, I think. I have talked about tumor biopsy, but in some lucky cases, we can do more than a biopsy, like the case I showed you in the lateral ventricle. Also in the third ventricle, sometimes we can remove completely or partially the tumor, like we did in this case. This patient had a tumor in the posterior third ventricle, and this is the postoperative image showing that we could remove completely the tumor with a flexible scope just by aspirating it. And we also did a ETV in that patient, and 1 year after, the patient developed symptoms of hydrocephalus because the ETV had a reclosure. So we operated again the patient to reopen the ETV, and we had the possibility to check, to inspect the area of the posterior third ventricle where we removed the tumor. And as you can see, 1 year after, the anatomy was still normal, no relapse of the tumor. This table shows a review of the literature of patients operated for the removal, partial or many times complete, of a tumor in the third ventricle with a complete, fully endoscopic technique. I have to mention the possibility to use ultrasound aspiration coupled with a rigid endoscope. There are several experiences in the literature. This is an example of coupling different techniques, endoscopy and also an ultrasound aspirator, which is very common in open surgery, and we can have many good results with this. Again, in the third ventricle, the possibility with an endoscope to remove colloid cysts. In the past, it was possible only to aspirate the content, but nowadays, with the improvement of the surgical tools and also of the experience of endoscopists, it's possible to remove completely the cyst, also the wall of the cyst, This is a case of colloid cyst of the third ventricle, as you can see from the images, and this is the removal. First, the content, in this case, was quite thick. In some other cases, the content is more fluid, and so we have to aspirate it. And we can also remove the wall of the capsule of the colloid cyst. This is the exploration of the third ventricle, which is completely free. Sometimes we can have some blood clots, but with a flexible scope, it's very easy to remove, like you are seeing here, just aspirating them. There are also some cases of craniopharyngioma where endoscopy can have a role. Of course, when we talk about craniopharyngioma, the first aim should be removal of the tumor. But look at this case, a 78-year-old woman, so quite old, and she complained symptoms of hydrocephalus. So we decided not to offer this patient very invasive treatment with craniotomy or transsphenoidal surgery, because her condition, general condition, was not good. But we decided to fenestrate the cystic component, which was actually blocking the Monro foramen, as you can see. And this is actually what I did. See the characteristic content of this cyst, which was, of course, aspirated. I will move faster. I entered a different concameration of the cystic craniopharyngioma, opening all of them. And at the end, I was able to go down to the tuber cinereum area, and I could also perform a third ventriculostomy. This is the cerebral aqueduct, so it was possible to reduce the volume of this cystic tumor and reduce the volume in the third ventricle. And at the end, I could open also, as you can see, the tuber cinereum. The basilar artery appeared, and the patient symptoms disappeared. In another very interesting indication is arachnoid cyst. So those cysts can develop in many areas. I choose this patient as an example, a huge arachnoid cyst, symptomatic in the quadrigeminal cister. In this patient, we did a frontal precoronal approach, endoscopic approach with a flexible scope. As you can see, the aqueduct is compressed by the huge cyst in the posterior third of the third ventricle. And here you can see how big this cyst is in the third ventricle. I will move faster just to show you that I made fenestration at the level of the suprapineal recess. This cyst was very hard. As you can see, I tried to poke it, but I was not able to perforate it. So I had to spend a long time to do coagulations, several coagulations. At the end, I was so desperate that I used this stylet of Fogarty balloon just to poke this very, very hard membrane. And I was able to make it more weak and with several small holes. And at the end, I was able to enter with a balloon and enlarge this fenestration. Here again, some small bleedings, but never get too much worried, just proceed with irrigations. And then I was able to enter the cavity of the cyst. Here, the cyst is starting collapsing, but I wanted to go inside the cyst, which is possible through the hole I made, and I entered the cyst. And it's very nice because after entering this cyst, a very interesting anatomy appears, very unusual for us, with a straight sinus, the tentorium at the bottom, the cerebellum at the tops. This is the free margin of the tentorium and the occipital lobe. So it's a very unusual view for us. This is the ampulla of Galen. Another possibility that the endoscope gives us is assistant in shunt removal in some patients. Look at this patient. This patient is a von Hippel-Lindau patient with many hemangioblastomas. One hemangioblastoma was located at the level of the infundibulum. She received a VP shunt many years before, and it was not functioning, so we had to remove it. Fortunately, I decided to inspect this patient ventricle with a flexible endoscope. I say fortunately because I could detect this hemangioblastoma just in front of the mammillary bodies, and see there is a small fibrotic connection between the hemangioblastoma and the tip of the catheter. So in these cases, if you just try to pull out the ventricular catheter, you can induce a dramatic hemorrhage in these patients. So what I did was to, of course, break this tiny fibrotic connection with coagulations, and then finally with a forceps, I interrupted this connection, and it was possible to safely remove the catheter. This patient is a 6-year-old patient with a hamartoma, hypothalamic hamartoma. This patient had gelastic seizures, and in such patients, endoscopy can be used to make a disconnection of the hamartoma from the hypothalamus. I used in this case a rigid endoscope. Here I'm entering the third ventricle. This is the wall of the third ventricle, and this is the hamartoma. Basically, what we have to do is to make a disconnection here at this level. So with several coagulations, I disconnected this hamartoma. No need to remove it. Of course, we took some bioptic samples, obviously, but no need to remove completely this benign tumor. Just disconnect it from the hypothalamus, and the patient's epileptic seizures were resolved. So what to use in the ventricles, a rigid or a flexible endoscope? As I said, as long as you are staying in the lateral ventricles and in the anterior part of the third ventricle, basically it's a choice of the surgeon what kind of endoscope to use. If you have to work in the posterior third of the third ventricle, you can choose to, if you want to use a rigid scope, to use 2 bar holes, one for working in the arterial part, and another one more anteriorly placed to take a biopsy of a tumor in this area, for example. Or sometimes you can choose to place the entry point in between these 2 optimal trajectories. But of course, in this case, you have to accept the fact that you can make some force at the level of the mongroforamen. Some authors proposed to use both a rigid endoscope to work at the level of the tuber cinereum, and through the same entry point, a flexible endoscope to work in the posterior part of the third ventricle. Schroeder and Gab published actually the possibility to use a so-called mother-daughter principle, so the flexible scope can be inserted through the working space of the rigid scope. In my experience, in these cases, so when I have to cross the mongroforamen, I always use a flexible scope. I feel safer using a flexible scope. And actually in our series, my personal series and the one of our institution in general, we never had a damage to the fornix using a flexible scope in all our more than 800 patients. So when you have to work in this area, I think it's preferable to use a flexible scope. What can you do if you cross this limit of the anterior part of the third ventricle. Of course, again, you can do tumor biopsies or removal, as we said, just to point out when is it possible to remove a tumor. Usually when the tumor is vegetating, so when it is exophytic, when the color is pinkish, it's more likely to be soft, so it's possible to aspirate it. And when it shows some small capillaries on the surface, and these are all signs of good aspirability of the tumor. Some groups showed there are also some techniques that can be used to remove these tumors, like using an instrument to, try to disconnect the exophytic tumor from the walls of the ventricle. And then in the cerebral aqueduct, we can sometimes perform an aqueductoplasty. Usually I do this aqueductoplasty when there is a membrane obstructing the aqueduct, but maybe the next patient is more interesting. This lady, this young lady, presented to our hospital with signs of subacute hydrocephalus. And during inspection, I found this membrane, transparent membrane, obstructing the cerebral aqueduct. So I fenestrated this membrane and restoring basically the normal anatomy of the CSF pathway. And here you can see I am navigating in the fourth ventricle very freely, just to make sure no other obstructions are present. This is the Magendie foramen. So in this patient, this aqueductoplasty allowed to resolve all her symptoms. But we have to be very careful in these patients. We have to distinguish true stenosis situation from a membranous occlusion of the cerebral aqueduct. Why? Because while in the case of a membranous obstruction, it is quite safe to fenestrate the membranous obstruction and fix the patient's problem. When a true stenosis, gliotic stenosis is present, we have to avoid performing aqueductoplasty in these patients and prefer ETV, because in these cases, if you try to perform an aqueductoplasty, you can damage the aqueductal periaqueductal gray matter, and the patient can have problems like diplopia. I always, when I think about the cerebral aqueduct and the fourth ventricle, I always think about ancient Greece. Why? Because the ancient Greeks thought that this was the world at that time. And they thought that there was a limit for navigation, which was called the Pillars of Hercules, which is actually the border between Spain and Morocco. So they thought that crossing this narrow passage would have been not only useless, but also dangerous, because only death could be found crossing this border. And I think the cerebral aqueduct has been seen by neurosurgeons like the Pillars of Hercules for endoscopy. Even after the introduction of the rigid endoscopes, we can inspect this area but not cross. Otherwise, we can have very severe damages. But with a flexible scope, it is possible to go beyond this limit. We can cross this limit quite safely in selected cases. There are several publications, for example, cases of fourth ventricular neurocysticercosis, which can be removed through a transaqueductal approach. Of course, in the fourth ventricle, we can also select a different approach with a retrograde, like a trans-Magendie route with a rigid scope, like this Japanese group did. But we can also use flexible scope with a retrograde route, like we did in this patient, who presented with several lesions in the brainstem and at the level of the superior medullary velum, which is actually a very difficult area to get biopsy from. In this case, I made a very small opening at the level of the posterior fossa, and I entered with a flexible scope through the Magendie foramen, and I took a biopsy. Here you can see the picas. I entered through the Magendie foramen the fourth ventricle. This is the opening of the aqueduct seen from the fourth ventricle. This is the superior medullary velum, and this is the biopsy which were taken. Or sometimes it's possible to get to the fourth ventricle from a transaqueductal route, like we did in this patient with a posterior fossa arachnoid cyst, which was followed up. The patient was doing fine, so it was a accidentally found arachnoid cyst, but after a few years, she complained for symptoms of hydrocephalus, and we did again an MRI scan, and as you can see, the cyst was enlarged. So what I did was to navigate into the fourth ventricle. Here I am in the fourth ventricle, coming from the aqueduct. This is the brainstem, the floor of the fourth ventricle. This at the bottom is the roof of the third ventricle, which is pressed against the floor by the large cyst. Here, with a flexible scope, I found my way in this narrow passage, and I got to the area of the Magendie foramen. This is the area postrema area, the obex area. Here you can see the pica, the left pica, and this is the cyst wall. I always look through the wall of the cyst to make sure that nothing is at the opposite side before attempting a fenestration. So I fenestrated it, and then I shrinked it with the coagulation. And at the end, you can see the cisterna magna is completely free. And withdrawing the endoscope, you can see the normal anatomy restored in the fourth ventricle. So the compression was resolved. I also performed an ETV in this case. Sometimes you can use a flexible scope or a rigid scope just to help yourself placing a shunt in the fourth ventricle. Some authors even designed a very, very tiny rigid endoscope that can be inserted inside the catheter to guide it with a visual guidance. There are several publications about also isolated fourth ventricle and endoscopy to place this kind of catheters. Some patients have a membranous obstruction of the Magendie and Luschka foramina, like in this case. Of course, in these cases, you can perform an ETV, but sometimes the ETV is very dangerous. Look at this patient. Actually, the basilar artery tip was very, very high and not so much space in the cistern to perform a safe ETV. So in such cases, we navigate the fourth ventricle to perform a Magendie-plasty, so basically fenestration of these membranes. This video is just to show you how this patient anatomy appears. Here you can see the canalis centralis medullaris. Here we are at the level of the calamus scriptorius. And now the Magendie foramen appears, which is occluded by a membrane, as you can see. So just fenestrating it can restore the normal patency of the CSF pathway. I think the best indication for flexible endoscopy is this situation, intraventricular hemorrhage. We all have experience of these patients. We know that this condition carries a very high mortality, up to 80% in some series. We also know that more than 20 milliliters intraventricular blood is lethal in cases of subarachnoid hemorrhage. And we know that this blood in the ventricles can be harmful for many reasons, because yes, there is an intracranial hypertension and hydrocephalus, of course, but also a chemical damage on the brain and the brainstem. So there is a need for a reduction of mass effect due to blood. How to get it? Of course, there are some minimally invasive methods, and there are also some very invasive methods that I think have no more role nowadays. But for sure, the most commonly used surgery is the placement of an EVD in these cases. It is a very simple procedure, and it allows a fast resolution of acute hydrocephalus. But we know that very often this EVD gets obstructed by blood clots, so we have to frequently replace it. Very often we have to place it bilaterally, and we have to wait for a long time before seeing blood wash out. So this implies a longer hospital stay with an increase of complications like infections. For sure, we can use fibrinolytic therapy to speed up the process, but it has been shown by many papers that we still have to wait many, many days before the CSF is cleared using fibrinolytic therapy. But we also know from the literature that the hemorrhagic dilation of the fourth ventricle is the stronger prognostic factor in these patients. And the only way we have to get rid of the blood also from the fourth ventricle and very soon is by endoscopy. Look at this preoperative CT scan. With endoscopy, we can obtain these results. So get rid of blood not only from the lateral ventricles and the third, but also from the fourth ventricle. And we can do this in a very short time. We have published our experience about this technique, showing that we can not only decrease the volume of the ventricles in a significant way, but it's possible also to reduce the mortality of these patients with a quite fair outcome. And it is also possible probably to reduce VP shunt dependency of these patients. Look at these graphs. So on the right, there are patients treated by EVD alone. The black bars are the postoperative patients who required VP shunt. And on the left, you can see the patients treated by endoscopic aspiration. And we found that the rate for VP shunt was significantly lower in this group of patients. So how can we do this kind of operation using a flexible scope? There are many available, but I encourage to use scopes with an external diameter of less than 4 millimeters. Otherwise, you will for sure damage the cerebral aqueduct if you use bigger endoscopes. And we use the operative channel of the endoscope as a sucker. The instrumentation is very simple, as you can see, three-way tap connected with irrigation system and with a syringe to do aspirations. The access point is crucial. It must not be too lateral because the cerebral aqueduct is a very tiny and median canal. And if you go too lateral, when you get there and you try to enter the cerebral aqueduct, it will be very hard to enter it. So we place usually our bar hole quite medial. And the maneuvers required are irrigation to unveil anatomical landmarks and aspiration, of course, to remove the blood clots. Here you can see our entry point, 2 centimeters from the coronal suture and 1.5 centimeter from the midline. We use a peel away to cannulate the ventricle. These are the different phases of this surgery. First, get rid of blood from the lateral ventricle. This is the most time-consuming part. The lateral ventricles are big compared to the third and the fourth, which can be cleared from blood in a very short time. So this video shows an example of this operation. Here I'm entering through the peel away into the lateral ventricle. Initially, when you start doing this kind of surgery, this surgery can be very discouraging, I have to say, because all you can see is this. We call it the Japanese flag, so all blood. all red, but you don't have to be discouraged. Just keep aspirating and stop aspiration when you see white, because when white color appears, it means you are facing the ependyma. Here, the first anatomical landmarks appear, so the interface between the clot and the ependyma. And if you keep doing aspirations and irrigations, you will find a very important anatomical landmark, which is the choroid plexus of the lateral ventricle. So the choroid plexus must be followed backwards to get rid of blood from the occipital horn of the ventricle, and can be followed also forwards to get to the foramen of Monro. Here you can see the fornix and the foramen of Monro, which is occluded by blood, of course. And when you are there, you have to do, again, aspirations from the anterior third ventricle to clear it. And very soon you will see the mammillary bodies here and the tuber cinereum here. Of course, the vision is quite hampered by the dirty CSF, but here you can see the infundibulum, the optic chiasm, the lamina terminalis, and then you can bend the tip of the endoscope towards the posterior part of the third ventricle. Again, you will find, of course, several blood clots that you have to aspirate. As I said, the aspirations here, the required aspirations are not so many because the third ventricle is a small ventricle. And after removing these clots, the addictum of the cerebral aqueduct will be unveiled. Here it is, the aqueduct with the posterior commissure, the habenular commissure, the pineal recess, and you can even inspect the suprapineal recess. Here you can see a cleared posterior third ventricle, and now we can actually navigate through the cerebral aqueduct doing the same maneuvers. I will go faster. So you can do aspirations and irrigations. So here you can see the brainstem, and if you remove more blood, the choroid plexus in the Luschka foramen and at the level of the Magendie foramen will appear. Here you can see the roof of the third ventricle covered by choroid plexus. And you can also navigate all the way at the bottom part of the fourth ventricle. This is the canalis centralis medullaris, the picus. This is the cisterna magna after the Magendie foramen. You can aspirate bloods and see, you can make everything clear from blood with these maneuvers. So these are the results. Again, we can obtain very nice results, and you can couple this technique also with coiling in case IVH is due to a ruptured aneurysm. We have performed some of these cases. Look at this, for example, a small anterior cerebral artery aneurysm, which was coiled. And immediately after, the patient was treated with endoscopy. So in less than 1 hour from this pre-op CT scan, we can have this situation, which is, as you can imagine, of great benefit for the patient. Again, another case of coiling of a basilar artery aneurysm. And immediately after coiling, we operated this patient to aspirate the blood clots. And in this case, look at this fourth ventricle and look at this situation immediately after the surgery. The results are very evident. I also use the same technique after clipping some aneurysms. And if you consider the very impaired situation these patients arrived with, we can get some fairly good outcomes. Like in this case of a left MCA aneurysm with intraventricular blood, I clipped this aneurysm, but as you can see, of course, I was not able to remove the blood from the third and the fourth ventricle and even from the lateral ventricle. So immediately after clipping, I did endoscopy, and this is the immediate result of this patient. I want to mention also the possibility to use endoscopy for intracerebral pathologies like an intracerebral hematoma. The standard of treatment is in this case is medical treatment, unless there is a life-threatening hemorrhage. In these cases, we can think, of course, about surgery, but many trials have been performed over the years for this kind of problem. And basically all these trials failed basically to show any benefit for the patient from surgery. However, endoscopy is now getting more validations for this kind of patients. To be honest, it was initially proposed many years ago by Auer, who used a rigid endoscope, but this technique was very soon abandoned in the following decades, but recently has been reproposed, sometimes coupled with some devices like the BrainPath Myriad or the Artemis device, which allow you to break down the stiff clots. These instruments can be inserted in the operative channel of the rigid endoscope. So you can basically remove these hemorrhages like this one in this patient with a single bar hole. I placed the bar hole in this patient at level of eyebrow. So I made an eyebrow incision, and with a single bar hole, inserting with a neuronavigation system, of course, a rigid endoscope, I was able to remove the intraparenchymal blood with this postoperative result. So with a very minimal access. After showing you all these clinical situations, I would like to spend my last minutes here with you, showing you also more speculative, maybe, result that we got after our experience. So basically, we have been able to explore thoroughly the ventricular anatomy of many patients. And with this kind of technique, with the endoscope, we have been able to describe the anatomy, the in vivo anatomy of the whole ventricular system. For example, we have seen the anatomy of the posterior part of the third ventricle. Here you can see the aqueduct, the entrance of the aqueduct, the posterior commissure, the abenular commissure, the pineal recess, and we have also observed the variations that were caused by some pathologies, like in case of hydrocephalus. As you can see, the commissures are more stretched, and the shape of the adytum of the cerebral aqueduct changes from a triangular to a more oval shape. In this patient, I operated for recurrent ependymoma of the fourth ventricle in the prone position. So I used prone position and a microscope. So it was an open surgery. At the end of the surgery, I inserted a flexible scope through the Magendie foramen all the way in the third ventricle, because the tumor was very bleeding, and I wanted to make sure that no blood clots entered the cerebral aqueduct. And actually, there were blood clots. I removed them, just aspirating them, and this gave me the possibility to inspect the third ventricle, the anterior part of the third ventricle, from a very unusual position, with a clear view of the two Magendie, of the two Monro foramina, the anterior commissure, and the triangular recess. Again, we described and we published the anatomy, in vivo anatomy of the cerebral aqueduct. As you can see from this video, there are several parts of the aqueduct. We can also see the pulsations of the cerebral aqueduct, showing that actually the aqueduct has a compliance. So we showed the adytum, the first constriction, the second constriction, and in between the ampulla of the aqueduct. And again, we described and published the anatomy of the fourth ventricle seen from an endoscopic view, of course. We described not only the anatomy of the floor of the fourth ventricle, but also the anatomy of the roof of the fourth ventricle seen from inside. And this kind of vision can be very important also for young neurosurgeons to understand some anatomical landmarks, especially when we have to perform a microscopic approach to the fourth ventricle, like the telovelar approach. Seeing the fourth ventricle from inside makes the anatomical landmarks much more clear than when we look at them from outside. Again, the use of fluorescent sodium injection allows us to see something that otherwise would be invisible, not only the choroid plexus, but also the tiny subependymal vascular network, which is surprisingly complex, especially if compared with the normal light anatomy that shows you only a partial situation. And with the fluorescent sodium injection, we have also been able to enhance some of the circumventricular organs, like I mentioned before. Look at these pictures and also at this video. This is a navigation through the pilloway. This is the lateral ventricle with the Monro foramen. Of course, when you turn on the fluorescent mode, you can see the choroid plexus enhancing. Not surprising, it is lacking the brain blood barrier. But here, look at the anterior part of the third ventricle. In the tuber cinerarium, we can see this median eminence, and at the level of the lamina terminalis, this circumventricular organ appears, which is the organum vasculosum lamina terminalis, which is otherwise impossible to be detected with normal light. Again, if we go to the posterior part of the third ventricle, only the choroid plexus can be inspected with this system. But if we navigate in the fourth ventricle, like we are now, and we turn on this fluorescent mode, you can see here at the level of the calamus scriptorius, this area, which is the area postrema, just 2 leaves besides the apertura canalis centralis medullaris, a very important and interesting circumventricular organ. So I want to conclude saying that rigid or flexible endoscopes can be used to inspect the ventricles or to do operations in the parenchyma. Of course, if you want to navigate through the cerebral aqueduct, it's required to use a flexible endoscope. In general, when you use a rigid scope in the third ventricle, you must be careful on the fornix, must not be damaged. If you have some bleedings, you have just to be calm and keep irrigating. Sometimes you have to be very patient, but in almost all cases, it's possible to control bleeding with this technique. Sometimes compression with a Fogarty balloon can be useful, or also the dry field technique. Aqueductoplasty can be performed, but only if the occlusion of the aqueduct is membranous. Otherwise, prefer an ETV. And another very important point is when you are in the fourth ventricle, you have to be careful in balancing aspiration and irrigation, because the volume of your scope basically occludes the cerebral aqueduct, making the fourth ventricle an isolated chamber. So you have to be very careful. Otherwise, you will have bradycardia. And IVH aspiration can allow a quick restoration of CSF pathways, decrease intracranial hypertension. It is a very low invasive technique, and we can, with this method, reduce shunt dependency of our patients. Thank you very much for your attention, and any question is very welcome.
Thank you very much, Professor. It was a spectacular presentation with amazing cases, and the videos were perfect. I would like to, before going through the chat, which is unusually quiet tonight, I'd like to ask from the audience, Professor Hayri Kertman from Ankara, Turkey. He's mastering endoscopic neurosurgery, so I'd like his comment or question.
I think he's left. the meeting.
Oh, okay. Okay, we can move on to Professor Abuzer Güngör. Can we unmute him? Yes.
Hi again. Thanks for your inspiring presentation. I learned a lot from you, but I think it is not.
Professor Güngör, your voice is not clear.
I must check.
I think he's muted now.
Okay, he can turn on. Yeah.
Yes.
What about now?
We can hear you.
Yeah.
Okay. Alberto, thanks for your inspiring presentation. As always, I learned a lot from you. And after your presentation last year, we started a project and finished. I will send you soon about the flow of the fourth ventricle. And in Turkey, I think it is not common to use flexible endoscope. What about in Italy and in the world, Alberto?
Yes, thank you, Abuzer. Actually, you are right. Flexible endoscopy is not common in Europe. Actually, I would like to know also the situation in Turkey, if it is common or if it is used by someone. I would be interested, but I can say in general in Europe is totally uncommon. If you go to other countries like Japan, for example, and you tell Japanese colleagues you are using a rigid scope to navigate the ventricles, they are looking at you like you are a crazy neurosurgeon, because they think that in the ventricles a flexible scope is safer. I have to say that I am more Japanese than European in this sense, so I also believe it's safer. But you know, there are several reasons probably why in Europe flexible scopes are not so common. There is a long tradition with rigid scopes driven by especially German companies. Although nowadays we have very nice endoscopes with a chip on the tip, so the quality of the image is perfect, like an intraventricular microscope, I would say. I think there is another major problem right now in the European Union, which are the new regulations by the European Union Committee, which basically require for all the instruments used in contact to the central nervous system to be autoclaved. Of course, you cannot sterilize a flexible scope by an autoclave. In that case, you will destroy it. And this is now required because many people are scared about prions. However, I think this is not reasonable, because I don't even remember the last case of a prion disease due to a surgery. For sure, there is no report of transmission of prions using an endoscope. I have checked several times. And also there is a test which can be performed in the CSF to rule out prions. So I think there is this is a problem that can really be fixed, but probably at the political level, the people who established these rules didn't understand that with all the benefits they thought to give, they are killing basically a technique, at least in European Union. So now we are not able to buy any new endoscope in this period.
Thank you, Professor, for your response. Now we have active chat, so I'm going to go through the comments and questions, if you don't mind.
Yeah.
Dr. Nurullah Kozmene from İzmir is writing, the lecture was great. Thank you, Professor. I will move on with Dr. Al-Fatih Muhammad. Thank you very much, Professor. Awesome lecture with invaluable insights. All the best. Thank you again. And we have a neurosurgery resident from Kazakhstan, Ayman Maidan. Thank you for your amazing presentation. When do you give a fluorescence before the operation? 2 hours prior? Is it Peros? Did you have a nausea complication after working on the area close to the area post-trauma? And what is the control city procedure after operation?
Yes, thank you for the very nice questions. So I first of all, I inject fluorescing sodium from a peripheral vein. So it's not peros, it's intravenous injection. The anesthesiologist usually does this injection, and I do the injection during the operation. So when I am already inspecting the ventricle or the tumor, because you can observe the effect and the enhancement in like 15-20 seconds after the injection. Mm-hmm. So when do I use fluorescing sodium? It depends. Sometimes, as I said, usually I do it before doing an ETV, just because I want to, if possible, preserve the median eminence when I perform an ETV. I do it when I have to take biopsies from a tumor, because I want to make sure about the vascularization of the tumor, the superficial vascularization. I use it before performing any fenestration of membranes, again, because I want to make sure the membrane is not crossed by vessels that should be maybe coagulated before. Then the question is about nausea. No, actually, I have never had this problem. Sometimes the patients postoperatively have nausea, but this is not related to the working area. So sometimes they have nausea also after a simple ETV, not necessarily when I work in the fourth ventricle. And to this perspective, I just want to mention that I think in the 60s, two neurosurgeons published a small series of patients having intractable vomit, and they did lesioning, microsurgical lesioning of the area post-trauma in these patients. And very interestingly, the patients recovered from their vomit problem. Oh. I'm saying this because I believe in the future these circumventricular organs might be a target for neuromodulation therapy, not necessarily lesioning, but from a neuromodulation point of view, they can be very interesting targets in this kind of patients. And about the CT,
control CT,
I'm not sure what's the question about that, but if the question is about complications, I have to say that I had no major complications except for one case, which I remember, a tumor in the pineal area, which turned out to be actually a metastasis. I did an ETV in this patient. She was an old lady. I did the ETV because there was an obstructive tetraventricular hydrocephalus. Then I directed my flexible scope all the way to the posterior part of the third ventricle to take biopsy of the tumor. But after disrupting the very tiny ependymal layer, I saw the tumor behind this ependymal layer, and it looked very vascularized. So this was the only case I aborted the biopsy procedure. So I didn't do the biopsy. However, after awakening the patient awaked very well. And 1 hour later, she deteriorated. She went in coma. I did a CT scan, and there was a huge, massive intraventricular hemorrhage, which I aspirated with a flexible scope. The patient unfortunately died in this case, which was quite surprising to me because it was the only case I didn't perform the biopsy, but probably there was a problem of pressure balance between arteries and the ventricle. So usually the CT scan is very encouraging after this kind of operations.
And we have follow-up question from Ayman. For pineal region of use endoscopic biopsy through the same burr hole as for ETV, or do you insert additional burr hole?
No, I always use just one burr hole. And the position of the burr hole, it depends. If you use flexible scope, you don't need neuronavigation, and the burr hole can be placed at the usual Cocker's point, modified if you have to enter the cerebral aqueduct. As I said, you have to place the burr hole a bit more medial. But if you have to stay only at the level of the third ventricle, the burr hole at the Cocker position is always good. Of course, if you decide to use a rigid scope, I encourage the use of neuronavigation.
Thank you. Another Bülent Düz from Istanbul private practice is saying flexible endoscopes are not flexible enough. I think that's the comment for the flexible endoscopes. Then we have a female neurosurgeon.
If I can comment on this comment. Well, I think it depends because as I showed you, with this kind of flexible endoscopes, I could go all the way from Cocker's point, entry point, to the cisterna magna very easily. And with the endoscope, I have never had problems of damaging the cerebral aqueduct or the fornix. So I don't really think the flexible scope are flexible enough, but I think the instruments which are actually currently provided for the flexible scopes are not flexible enough. So the real problem is not the flexible scope, which is flexible enough, but the instruments, so the forceps, for example, those instruments, I agree, are not flexible enough. So there is a way to improve this kind of technology, because every time you use an instrument inside the working channel of the flexible scope, and maybe the flexible scope is a bit bent, the feeling is that the instrument is changing the curvature of your flexible scope, because the instruments are more rigid than the endoscope itself.
Thank you. Now we have a female neurosurgeon from Turkey, Dr. Selim Bozdak. Thank you, Professor. Although I don't have cerebral endoscopy in my daily practice, I listened with interest. And we have another comment from Uzbekistan. Dear Professor Alberto Feletti, I wanted to express my sincere appreciation for your excellent presentation. Your insights were enlightening, and I truly value the knowledge you shared. Best regards. From Lukman Achilov, Uzbekistan.
Thank you, Lukman, which I know. So this is a bias. There is a bias in this very nice comment. I want to thank Dr. Lukman.
Professor Suju, do you have any comments or questions?
Not actually. I want to thank again to.
I have a couple of questions actually.
Sure.
I wanted to ask for young neurosurgeons such myself, I'm interested about the learning curve. What is the learning curve for mastering endoscopic neurosurgery?
Yeah, good question. I think that nowadays a neurosurgeon must master both rigid and flexible endoscopes. So to a certain extent, both instruments have a common learning curve initially, at least for operations in the lateral and the anterior third ventricle. Of course, my advice is to start from the simplest operations. First, shadow an experienced endoscopist to see as many operations as possible. This is what I have done. I have been lucky. My first chair when I was a resident, Professor Longatti, whom I thank a lot. Is a master in this technique, and I have scribed with him many times. You know, the most important part initially is to get familiar with anatomy, because the anatomy of the ventricle from inside is not easy to understand. You have to master it first. Second, when you start doing it by yourself, start with easy operations like septostomies, like fenestration of membranes or cysts in the supratentorial area. Then, of course, ETV. ETV can probably be considered as like a basic neurosurgical operation. Every neurosurgeon should be able to perform that. And then after that, you can move on with biopsies of tumors, maybe removal. Sometimes it's possible, as I said. I would say that the last step of the learning curve is to navigate the cerebral aqueduct and perform surgeries in the fourth ventricle. So it's very important to follow these steps with this sequence, I think.
Mm-hmm.
The learning curve, you know, it depends, the length of the learning curve depends on how much you are exposed to this kind of surgery as any other operation, of course.
And Dr. Nurullah is interested if you have a fellowship program in your hospital.
So, yeah, in Italy, we don't have actually proper fellowship programs in general. The regulations in Italy are quite strict for scrubbing in. So if you don't have an Italian license, you are not enabled to scrub in. But our institute has many international contacts, and we have many fellows, many observers visiting us every year. So we are always very happy to welcome people who want to come here and to observe surgeries or to be involved in some research project.
Dr. Eralp, thank you very much for your response. I see one question appeared in the chat. Eralp Chetinalp from Çukurova University is asking, do you use dry field technique when using Fogarty balloon compression, or is it CSF while trying to control bleeding?
So again, also the managing of bleeding must follow some steps, I would say. I always start with irrigation, because being patient is a requirement for an endoscopist. Most of the time, I could control the bleedings just by irrigation. Keep irrigating. Sometimes I waited up to 30, 40 minutes. Rarely, I have to say, but it happened and it stopped. In some cases, maybe, you know, with age, I'm getting less patient. So after some minutes of irrigation, I used a Fogarty balloon. I inflated the balloon to compress the point of bleeding. Again, it's very important to irrigate precisely, to identify precisely the vessel which is bleeding, and then use the Fogarty balloon to compress. And if also this is not enough to control the bleeding, you can use the dry field technique. As I said, it happened to me just once so far, but I have to say that it was very effective. So I aspirated all the CSF, and the bleeding, basically, I didn't have even to coagulate anything. I just waited, and the bleeding stopped. And then I re-infused saline in the ventricle, and the bleeding was stopped.
Thank you very much. And one last question. Actually, it's not so with regards to endoscopy, but I just couldn't miss the chance. When I was going through your publications, one of the articles caught my eyes. It was published in Frontiers of Physics, and it's a collaboration with your fellow colleague astrophysicist, and the title says quantitative comparison between the neuronal network and the cosmic web. And it compares the galaxy and universe with our brain and neuronal network. I wanted you to elaborate more on the details. I think audience will be interested in that. What was your findings and what are your plans? Like, are you going on with the research in that field and seeing more similarities between the universe and the brain and how they work?
Yeah, thank you for the question. This probably would require a separate webinar because it's a very complex field. Complex and I would say dangerous, because when we decide, okay, the astrophysicist I published with is a dear friend of mine. We were mates from the elementary school throughout middle school and high school, and then our path separated. But we kept in contact, and I remember exactly when we had this idea of comparing the two systems. It was drinking a beer at our hometown. So sometimes interesting ideas can be found during relaxed time. You know, there are many websites, I would say, or many also papers in weird journals comparing neuronal network and galaxies. You can find many. But those are only qualitative comparisons, so just visual comparisons. So we decided to make something more scientific using some algorithms that usually cosmologists use to analyze galactic filaments and galaxies. And we compared the cortex of the brain and of the cerebellum with these galaxies and filaments. And we did the network analysis and also spectra analysis. And surprisingly enough, these spectra and this network analysis showed very, very significant similarity between the two systems. We also included in our analysis other natural networks, like branches of the trees, you know, the small nerves in a leaf or the clouds, and none of these systems were similar to these two systems. So the speculation is that probably nature is finding some common ways to develop networks when the network is complex enough. I want to say in this webinar that we didn't have any intention to say something more than this. I'm saying that because after the publication, we received many comments, of course, and most of them were from people saying thank you because you demonstrated the existence of God, or thank you because you showed that the brain is a universe, or a universe is a big brain. It's nothing like that. We didn't want to say anything like that, and we pointed out in the paper, actually. It's merely an architectural comparison. What we want to do, we have already plans to move on. We are moving on with this project. What we did is a comparison on a 2D scale. What we want to do is a comparison on a 3D scale. So we are now working on this kind of comparison to try to confirm our results.
Thank you so much. That sounds really exciting. And Professor Suju, I think we can invite you for one more webinar, and the audience will gladly listen.
Sure. And I want to thank again to Professor Feletti for this wonderful lecture. And I want to make it clear for Nurullah Kösmen's question. As I understood from your answer, Nurullah Kösmen, one of our residents, he can come to your hospital to see you, to see your operations.
Yeah,
as long as he wants, but he cannot scribing and he cannot join your operation, but inside of the operating room?
Yeah, correct.
Stay?
So the problem, anyone is very welcome. We always receive people at our institution, but unfortunately in Italy, it's not possible to scrub in during surgery. Not possible to be active part of the surgery because of these regulations requiring the Italian license. However, they can absolutely enter the operative theater and observe operations from like 1 meter, okay?
Very close.
Very close. Not scrubbing in, unfortunately, but absolutely they can enter, they have to enter the operative theater, and they can discuss with us the cases, follow the ground rounds, discuss pre-operative cases, watch the operation during surgery, follow up the patients after that, join our lectures or academic events. Of course, this is possible. What is not possible is to scrubbing, unfortunately.
Thank you so much.
Thank you so much, and thank you for the audience for their contributions, Professor.
Is there
We
anyone else
appreciate
who
you.
want to talk? You want to make a comment for last time? Abuza, Professor Güngör, would you like to send something else? Say something else?
I am a supporter of the transcallosal resection of the third ventricle coagulate cyst. Because as you know, in endoscopic surgeries, there's a higher subtotal resection and recurrence rate. What about in
Professor Güngör, your voice is still not clear, and maybe
Yeah.
you keep close to microphone. Maybe it will be better. Yeah. Also, Professor Bülent Düz
now?
will talk. Okay.
Yeah.
Again.
So your question, Abuzer, your question was about colloid cyst.
Microsurgical resection of the third ventricle coagulate cyst.
Yeah.
Because of an endoscopic resection has higher rates of the subtotal resection and recurrence rate. And what about in flexible endoscopy?
Yeah. Okay, very good question. Actually, this topic has been very much debated over years. First of all, I want to say that I don't think one method is superior compared to the other. I think it's difficult to say that. I agree about the fact that historically, the endoscopic technique got a higher recurrence rate, for sure. I mentioned during the presentation that initially the habit was just to fenestrate the cyst and aspirate the content. So if you do just that, you will have a high recurrence rate, for sure. With the advancement of technology and with the use also of a flexible scope, which can be coupled also with a rigid scope, you can start the operation with a rigid and then inspect the roof of the third ventricle with a flexible scope at the end, for example. I'm not saying that you must use only flexible scope, but if you use also that, you can have a very nice view of the roof of the third ventricle, and you can grab the wall of the cyst. There are several papers, several series published in the literature in the last years by names which are bigger than my name, showing that the results are wonderful also at a long follow-up. Because if you are able to remove totally or also subtotally, if you remove 80% of the wall of the cyst will not come out anymore. So sometimes you have to leave a very small piece of the capsule which is attached to the internal cerebral veins. So in my experience, this happened in a very limited number of cases. So in most of my patients, I was able to patiently, of course, carefully remove the cystic wall And so far, I have no memory of recurrence of colloid cyst in these patients, compared to a very old experience of the first endoscopic attempts when the cyst was just fenestrated with aspiration of content. In those cases, if you use that technique, of course, you have to expect a high recurrence rate.
Okay.
Dr. Bulent Tuz wanted to contribute. Yeah.
Hi, can you hear me?
Yeah.
Yeah. Okay. Thank you very much for your giving me the opportunity to talk. Thank you very much, Professor, for your great experience for sharing with us. I'm very glad to hear you because your fluorescence experience is extremely, I think that in an extreme valuation for the endoscopic neurosurgery. It's really an advancement for us. Actually, I have similar experience with you because I have more than 300 patients operated with endoscope, but I am using ventricular port technique for last 18 years. We have started to work on that area in endoscopic neurosurgery 18 years ago, and 15 years ago we have bought one flexible endoscope, but it was I thought that it was not enough flexible, so I was afraid of using it because I thought that it made damage to the brain, and it made I have never used it inside the brain. But I liked your experience very much, and I want to for a question, if you let me to ask a question. My question is, what's your opinion about ventricular port technique in that area? Because I saw that you are using only the classic endoscopic technique.
Yes. So first, well, thank you for your comments and for your question. You work in Turkey, right? If I got it straight.
Right.
So I don't know which kind of flexible endoscope you have bought 15 years ago, but 15 years ago there were instruments that nowadays are very different. So my encouragement is to try to use the new flexible endoscopes. Turkey is not part of the European Union, although you are trying to enter. So European Union is something great for many things, but for this specific point gives us some problems, as I said. So we are not allowed to purchase the newest flexible endoscope with the chip on the tip. But as Turkey is not under this kind of regulation, you can buy or try this kind of flexible scopes. My advice is to try the newest ones. I had the fortune to try for some reasons, and they are unbelievable instruments, really. About your question, the ventricular port technique is a nice technique. I have used it in a few cases, but I think it depends on your experience. So I grow up with this kind of experience using just a peel away, which is very small. Probably sometimes it can be considered not enough in some cases. But for most of the surgeries I have done using an endoscope, it was enough. So this does not mean that I think the ventricular port should not be used because we can do everything with a peel away. No, it's not like that. I'm saying that probably there are most of cases can be performed with a peel away, as I showed you. It's possible. Of course, it depends on the pathology. If you want to remove a bigger tumor, probably the endoport is better. So it depends on the situation. I used it sometimes. I used also this kind of ports for intraparenchymal pathologies using an endoscope, a rigid endoscope. So I think they can add something to our practice. I agree with you. It depends on the location and the size of the problem, I think.
Thank you very much. And we have one last question from the chat. Dr. Ayan Kanat is asking, many thanks for this excellent presentation. In literature, there are some case report about sudden death following third ventriculostomy. What do you think about this topic?
I guess the colleague is referring to inadvertent damage to the basilar artery. So, of course, as I said during the presentation, ETV, although it is considered, easy surgery, it's not so easy sometimes. It's very, very important to inspect carefully the preoperative images, especially the sagittal MRI, the median sagittal MRI, because you want to make sure where is the position of the basilar artery. Sometimes the basilar artery tip is too high, and this increases the risk of damage. Sometimes, as I showed you, probably you remember the case of the huge cyst in the cisterna magna, which was compressing the brainstem against the clivus. Sometimes you don't have enough space in the interpeduncular cistern. So you must study very carefully the preoperative images to understand the safety of ETV. And then when you do the inspection, you have to look with this endoscope at the floor of the third ventricle to make sure you can do it. As I said during the presentation, in one case, I entered the operative room thinking it was difficult, not so much space in the system, but I was quite confident to be able to perform the stoma. But inspecting the area, I aborted this operation, and I preferred to place a VP shunt. I, of course, informed the patient of this possibility before starting the surgery. But if you are not sure about the safety of your ETV, it's better to give the patient a VP shunt and let the patient alive with a catheter instead of having tragedies. In my experience, I have fortunately never had this kind of complication. And also, I have never seen this kind of complication from my master, but it's possible, and we have to keep it in mind.
Thank you so much, Professor, for your response, for your time, for your invaluable insights. Professor Suju?
Thank you so much. I have no other question. Maybe Nurullah? Okay.
Thank you.
Well, I also want to thank you, Madonna, for the moderation, the questions. Thank you, Professor Suju, for the invitation. I'm really grateful. It was an amazing discussion. It's always useful also for me. I learn more and more when I take part of this to this kind of webinars. And thank you, well, Abuzer. He's a friend, so it was very nice to see him here. And also thank you to everyone who participated, attended this webinar, and asked me questions. Thank you very much.
Also, Nurullah Kösmene, our resident, is here, and he will come to Italy.
Oh, yeah,
to
sure.
Your operations.
Let's keep in touch, and I will be very happy to welcome your residents, your colleagues, of course, also you. You are very welcome to visit.
Thank you so much.
Thank you.
Grazie.
Bye-bye.
Grazie.